Today we'll be talking about cystic fibrosis. So what is cystic fibrosis? It is a condition where there is defect in CFTR gene. Now what is CFTR gene? Cystic fibrosis transmembrane conductance regulator. Okay, this gene is present on chromosome 7 and this gene codes for ATP gated chloride channel. Okay, chloride channel is the important part here, right? Now what happens here is, what is the defect? There is a deletion of phenylalanine at 508 position. Now what happens when there is a defect in CFTR gene? This chloride channel is defective. Now what does a chloride channel do? It basically secretes chloride in the lungs and GIT and reabsorbs chloride in the sweat glands. Okay, so here in the airway it secretes chloride, and in the sweat gland it reabsorbs chloride. Okay, so what happens normally when the CFTR gene is normal, the chloride is secreted outside and there's a sodium channel over here, ENaC, right? This sodium channel reabsorbs sodium, and wherever sodium goes, water follows, right? Now what happens if there is a CFTR gene mutation? The chloride is not excreted, but there is reabsorption of sodium and water. Now what does this do? The mucus becomes dehydrated because of this. Similar thing, when there is CFTR gene encodes chloride channel secretes chloride in lungs, GIT reabsorbs chloride in sweat glands. Phenylalanine 508 deletion, and because of this deletion there is a misfolded protein. Normally when there is a normal protein, right, ribosomes produce normal CFTR protein. This goes to Golgi complex and then attaches to cell membrane. Okay, but when there is a misfolded protein, right, CFTR gene is misfolded, this is taken to proteasome and there it undergoes degradation. So the misfolded protein, improper protein trafficking happens and protein absent from cell membrane. This does not get attached to the cell membrane. Because of this, there is decreased chloride and water secretion, compensatory increased of sodium reabsorption via epithelial sodium channels, ENaC, and increased water reabsorption. Abnormally thick mucus secreted into lungs and GIT. Increased sodium reabsorption, more negative transepithelial potential difference. If we come to the diagnosis, there should be increased chloride concentration in the sweat, right? But sometimes it so happens that the sweat chloride levels comes normal, and if you are confident okay, this might be cystic fibrosis, then what you can do is do a nasal transepithelial potential difference. Okay, and if it is more negative than normal, then that implies it is cystic fibrosis indeed. And one more point, we see that there is dehydrated mucus and sodium and water are reabsorbed, correct? And because of this, you will see contraction alkalosis, dehydration effects basically, right? Analogous to loop diuretic effect. So you will see hypokalemia and contraction alkalosis. Now we'll discuss complications. There are basically two things that you should remember. One is chloride glands are present in the lungs and in GIT, right? So there will be complications in the lungs and GIT, right? What happens in lungs? Because the mucus is dehydrated, it cannot trap microorganisms, correct? Mucus is supposed to trap microorganisms and then remove them outside. But here the dehydrated mucus cannot do its work properly, and that's why you will be facing recurrent pulmonary infections. And in addition to that, because this mucus becomes thick, it can block airways and it can cause airway irritation. So you will also experience chronic bronchitis and bronchiectasis. Okay, the thickening of mucus that goes and sticks to the airways and irritates the airways is bronchitis. Right, now pulmonary infections, if we are talking about, there are two main organisms that you have to remember. First is in children, in early childhood, there's a risk of most common organism that you can experience is Staph aureus. Okay, especially if you remember in influenza chapter in Sketchy Micro, you remember they mentioned that influenza is more susceptible to Staph aureus, right? So post influenza, patients can get a Staph aureus infection. So in young children, most common organism is Staph aureus, especially in the setting of concurrent influenza infection. So if the patient has influenza infection and then he has gotten a pulmonary infection, if you are suspecting some other gram-positive organism, then you can suspect Staph aureus as the most common organism. So for Staph aureus, what are we going to give? We are going to start with empiric vancomycin. And the second most common organism that is present mostly in the elderly patients is Pseudomonas aeruginosa. And in addition to that, you can also see nasal polyps and nail clubbing. Now coming to the GI tract. So what does it do in GI tract? Chloride channel. So it can cause pancreatic insufficiency, malabsorption, steatorrhea, fat-soluble vitamin deficiencies, progressing to endocrine dysfunction, biliary cirrhosis, liver disease. So basically, it's gonna affect all the GI organs: liver, gallbladder, pancreas, intestines. And the third thing you have to remember is it can cause infertility in males. So there is absence of vas difference. You have to remember this, like this is the differential diagnosis, right? There is infertility in males in both cystic fibrosis and Carter syndrome. In cystic fibrosis, it is due to absence of vas difference, okay? But in Carter syndrome, the vas difference is present, but there are the cilia are immotile, the sperm become immotile, right? That is the difference. So here the absence of vas difference, spermatogenesis is unaffected, so they can go for IVF or any other kind of procedure. And subfertility in females, amenorrhea and abnormally thick cervical mucus. Now coming to treatment, what is the treatment for cystic fibrosis? Chest physiotherapy, aerolyzed DNase, Dornase alpha, inhaled hypertonic saline, because we know that the mucus is dehydrated, right? So if we give it hypertonic saline, it becomes a bit hydrated, and this will help in mucus clearance. Azithromycin prevents acute exacerbations. For anti-inflammatory effect, you can give ibuprofen. If the patient has pancreatic insufficiencies, you can give enzyme replacement. And the last one, this is the big gun for the cystic fibrosis. It is CFTR modulators. They are either potentiators or correctors. So what are potentiators? Potentiators basically keep the chloride gate open so that the chloride can pass through. Example is ivacaftor. What is corrector? Helps CFTR protein to form right 3D shape. Example, lumacaftor and tezacaftor. Now what this corrector is doing, it's affecting this part. It is correcting the misfolded CFTR gene so that it can go and attach to the normal cell membrane, right? So potentiators keep chloride channel open, and correctors correct its position over here where there is misfolding. Let's just review all of it in detail. First thing, cystic fibrosis, mutation in CFTR gene. Because of this, there is impaired chloride transport, viscous secretions in lungs, sinus and pancreas. Now, what is the work of CFTR gene? Chloride secretion in lung and GIT, chloride reabsorption in sweat glands, right? So it is autosomal recessive, European ancestry. What are the clinical features? As we know, two places it affects. One is lungs and one is GIT, right? So what does it do in lungs? Recurrent sinopulmonary infections. In addition to that, bronchiectasis, bronchitis and nasal polyps, all of these things are done by cystic fibrosis. Now coming to GIT, it affects all the organs. In pancreas, it can cause insufficiency, pancreatic diabetes, and in liver, it can cause liver disease or biliary cirrhosis, and in intestine, it can cause malabsorption, steatorrhea, and in kids, it can cause intestinal obstruction, meconium ileus, because it thickens all the secretions, right? And male infertility, here the vas difference is absent. Whereas in Carter syndrome, the vas difference was present, but the sperm is immotile over there. Okay. Now coming to the diagnosis, it's very important. The chloride levels in the sweat are elevated, but in some patients, when the chloride levels are normal and you suspect cystic fibrosis in that patient, what are you going to do? You're going to do a nasal potential difference. So it is always more negative than normal. So that confirms cystic fibrosis. And you can also do a genetic testing, CFTR mutation. Now management. Management is basically respiratory support, airway clearance, and nutritional support, antibiotic coverage for Staph aureus and Pseudomonas. Staph aureus is the most common infection in the childhood, and Pseudomonas is in adulthood. So for Staph aureus, we give vancomycin, and for Pseudomonas, 4th gen cephalosporin, cefepime. For management, chest physiotherapy, inhaled hypertonic saline, aerolized Dornies alpha, azithromycin prevents acute exacerbations, ibuprofen for anti-inflammatory effect, pancreatic enzyme supplements for pancreatic insufficiencies. There are CFTR modulators. There's potentiators, which holds the gate of CFTR chloride gate, ivacaftor, correctors, which basically correct the misfolded protein, lumacaftor and tezacaftor. Now, normally, what does a child's growth chart look like in cystic fibrosis? So, initially, the birth measurements are normal, but subsequently, there is failure to thrive. It is characterized by weight deceleration crossing more than or equal to 2 major percentiles, followed by deceleration in linear growth velocities. That is it about cystic fibrosis.